So we're doing CBCs, CMP, and within the CMP is the LFT and the kidney panel. So we'll start with a little bit of the CBC, kind of organizing and going through the anatomy and physiology of your CBC first. So I've started here with the stem cells. And stem cells can be any cell, right? They're now like transplanted in different areas of the body, and they can become whatever that cell is that is lacking. But here we're dividing them into the two main ones that are part of the hematology and immunology. And so that would be the lymphocytes on this side and then the myelocytes on this side. So myelocytes as in bone marrow, right? And then your lymphocytes, which is the lymphatic system. This is obviously more immune. This is more hematology and some immune. So in the bone marrow, we have several cells that develop, one of them being the erythrocytes. And our normal value for erythrocytes is what? Normal lab. Not quite. So this is your 4 to 6. Okay, 4 to 6. Oops. So RBCs are normally 4 to 6. I try not to remember like a different set of values for females and males. I just try to remember like a huge range of values. And then like in my mind, that range, I just kind of slide it to the right for the males, slide it to the left for the female. So the females is kind of the lower end of my range, and then the males are the higher end of my range. And I'll teach you another technique to remember if you haven't heard it already. So, but for now, let's just kind of list them all. So we know the erythrocytes, RBC is 4 to 6. And the RBCs are also contained in the hematocrit, right? And hematocrit is measured in percent. So what are we actually looking at in hematocrit? What is hematocrit? What is it measuring? In whole blood. Yeah. So RBC in whole blood, right? Basically, it's like a ratio. So how much of the whole blood is RBC? So if we were to get, let's say, a 10 cc sample of our blood, that's the whole blood. When you put that in the centrifuge to spin it, the RBC is going to go down, right? And then, so your RBC might be, so let's kind of illustrate that here. So let's say you have like a vial of blood, and you put it in a centrifuge. So maybe around this much will be RBC. So if this is 10 cc's, just roughly, how much do you think is this out of 10 cc's? About 50, right? About half, right? So the 50% or 5 cc's. So your hematocrit is actually, I'm going to put the value after I put the hemoglobin. Then it'll make more sense to you guys as far as mnemonics and how to remember them. So in the RBC is the hemoglobin. So we'll put hemoglobin here first, and I'll come back to the hematocrit. So the heme part of the hemoglobin is what your iron attaches to. The globin is where the oxygen attaches to. So your hemoglobin normal value is, anybody know? Any idea? Yeah, so 12 to 18. So to kind of give you a memory tool, if you know your RBC, which is 4 to 6, multiply that by 3. So 4 times 3 is 12, 6 times 3 is 18. Now going back to the hematocrit over here, you can do the same technique. So then you multiply your hemoglobin times 3, which becomes 36% to 18 times 3, 54. It's been a long summer. Woo. Okay, so also when we do an H and H, right? So when we do an H and H, it's hemoglobin and hematocrit. So we're looking at this ratio. Are they equal parts, so to speak? Okay, so 12 for the hemoglobin would equal about 36% of hematocrit, roughly. Or if the hemoglobin is about 18, so roughly that's about 54%. Just so you can see if, what kind of deficiency the patient might have, okay? And then we also would look at other things that are related to RBC. So we would want to look at the MCV. And MCV is mean corpuscular volume. So this has to do, we kind of remember this as the size of the red blood cell. Okay, it's the size of the red blood cell. I'm going to put on here, actually, no, I'll put it later as far as like what that means. So I'll come back to that. We'll just put them all for now, list them all. And then we also look at your MCHC, which is your mean corpuscular hemoglobin concentration. And we kind of want to look at this as the shade of the RBC, right? So we wanted a deep enough shade of red. We don't want it pale, okay? And then as far as size, we want it just the right size. We don't want it too big. We don't want it too small. And then kind of along those lines, so these erythrocytes here, before they become erythrocytes, they are first reticulocytes. So reticulocytes are your immature RBCs. Okay. There should only be about roughly 1% of the blood that is immature RBCs out of the entire whole blood. But there are certain conditions where that might increase. So I'll speak about that in a little bit. And then we also measure, so again, back to our RBC. So we have the size, we have the shade, and then we also have the shape. And the shape sort of is seen in our RDW, which stands for red cell distribution width. Okay, so you can look at this as how wide is the RBC. Okay, so we're looking at how the size, how big. We're looking at how deep is the shade of red. And then we're looking at how wide is the RBC. Now, something extra that they might order that's outside of the CBC, but sometimes will give us a better look at the RBC. I'll just put it here as an extra thing that they put. So this is actually not part of the CBC, but we do a peripheral smear. So this is what looks at the shape or shapes of the RBC. And because this is through a microscope. Okay, so what they'll do is they'll get that RBC, put it in a microscope, then they'll be able to see if there is any ovalocytes. So ovalocytes mean that it's oval shaped. And that oval shaped RBC will correlate with the RDW, because if it's oval, then that means that it's wider rather than circular. So then that increases your RDW as well. And both of that would indicate to you that there's some kind of anemia going on. Okay, and I'll speak to anemia a little bit because that's commonly what we see. So I'll talk about that as we move along. So far we've talked about RBCs. These are our normal values. And then the hematocrit tells us how much RBC is in the blood in form of percentage. And then we have the hemoglobin here, which is what carries the oxygen. And then we have the MCV, which is the size of the red blood cell. And then we have the MCHC, which is the shade of the red blood cell. And then we also talked about the reticulocytes, which is the immature red blood cells. And then the RDW, which is the width of the RBC. And then moving along to other parts, other cells that develop in the bone marrow. Then we also have the here, leukocytes. Which are our WBCs, right? And that WBC as a whole is about how much? Okay, so I'm gonna put like the wider range that I've been seeing a lot more in hospitals now, which is about 4 to 11. But classically, you know, like in a lot of textbook, it's still 5 to 10. Okay, so we'll put 5 to 10. So if it goes to about 11, that tells you, okay, there might be maybe some sort of infection going on, but that's not significant. And then if the doctor orders, if the provider orders a differential, then that tells us, I'm going to put this a different color so we can separate out the different types. That tells us that they want to classify the types of leukocytes, right? In the bone marrow, we have the granulocytes, and the granulocytes are your neutrophils. And your eosinophils. And then your basophils. I'll come back to the other types of WBCs that are not myelocytes. Okay. But as far as the granulocytes, these are the ones. Basophils. Last one. Okay. Neutrophils are necessary for what? What do we use neutrophils for? These are for bacterial infection. Okay, so meaning if this number is increased, that tells you that there's a bacterial infection going on. if the numbers are decreased, that tells you that this patient is at risk for infection because they don't have enough neutrophils to protect them, okay? Which is something that happens with your chemo drugs as well. Eosinophils protect against, well, let me rephrase that. It slightly elevates with your allergies. Okay, so if someone has sinus allergies, you might see like a slight increase in your eosinophils. However, if it's greatly increased, like maybe 10-fold, 100-fold of what the number should be, that is likely a parasitic infection. Your basophils also will increase when there's allergies because it's driven by histamine and also clotting. Okay, so if this is increased, that means that there's probably some kind of bleeding going on that is trying to protect the patient from. Okay, we'll come back to that some more in a little bit. And then we also have our your thrombocytes. That's part of your myelocytes. And of course, these are our platelets. And normal value of platelet, 150 to 400. Okay, and of course, this is for clotting. Okay, the other part, the other component that is in the bone marrow is your monocytes. And your monocytes are in your blood, but then at the site of where it needs to protect, it becomes your macrophages. And what is the job of macrophages? Phagocytosis. Okay, so far, these are the components that we will see in the bone marrow. Okay, so these are your myelocytes. And then over here, where we're talking about the lymphocytes, this is the other part of your differential. So if there's a CBC with diff, that would be your leukocytes being broken down into different parts. And we have used the mnemonic, never let monkeys eat banana. Everyone aware of that one? Okay, we'll write that out over here separately. It's a good mnemonic to remember because it's in the order of quantity. So never let monkeys eat banana, right? Never let monkeys eat banana. So that's your neutrophils, followed by your lymphocytes, followed by your monocytes, and then your eosinophils, and then your basophils. So the quantity of these guys, the WBC is nominated by your neutrophils. So neutrophils is about maybe 40 to 60%, or maybe roughly around 55. So about, we'll say 50 to maybe 65% of all the WBCs. That's why if we don't do a differential and this number increases, our first assumption is this is a bacterial infection because this is majority of the WBCs. Of course, if this is increased, then it increases the whole value. But if we're not sure what's causing it, then we do a differential because, you know, who knows, it might be something that affects the lymphocytes, or it could be the eosinophils or the basophils. So neutrophils about 50 to 65%. Lymphocytes approximately maybe around 40%. Your monocytes are roughly around 10 to 20%. Eosinophils around 10%, and these are rough estimates. And then basophils, maybe 4%, 5%, or even 0. Okay. It's okay for the eosinophils and the basophils to be very low. That just means that there's no type of a pathogen or allergen that the body is fighting that needs the eosinophils or basophils. Okay. Now here in the lymphocytes, so here we've said that neutrophils is increased when there's a bacterial infection. Eosinophils is increased when there's an allergic parasitic invasion. Basophils when there's histamine or clotting issues. Now here on our lymphocytes, let's talk about the two different kinds of lymphocytes, which is, anybody? So you have your B cells, and they're called B cells because they mature in the bone marrow, right? They mature in the bone marrow. And then they are abundant. They are when they're when they're just normal cells, not becoming memory cells yet. They are what kinds of cells? Where are they? Where do you find them? The bone marrow is where they develop, and then they come out of the bone marrow, and then they become plasma cells. Okay. And because they're in the plasma, so they're abundant in the blood, right? So then when they encounter an antigen, they become memory cells, right? And when we say memory cells, these are your, what kind of proteins are these? Immunoglobulins. Okay, so that is when there's a antigen, right? They attach to the antigen, then they remember what that antigen's makeup is. That way they could tell the T cells, right? So the main T cell is our natural killer T cells, which are your cytokines. And then, of course, these are important in viral and cancer fighting. Okay, so viral infections or any type of cancer. So they try to prevent cancers from happening. The other types of T cells, that are two types of T cells, are your, anybody? Helper and? So your helper T cells, which are your CD4 and your, anybody know? Suppressor. So there should be a balance between your helper and your suppressor and your killer, right? So the suppressor should be activated when There's no more virus or cancer cells to kill. That way, it doesn't end up in an autoimmune disease, right? Because if you don't have any suppressor cells, then the killer cells could just be, you know, killing and killing and killing, even though it's not necessary to kill anymore, right? We'll come back to that when we talk about, I'll kind of give you a little preview of HIV when we come back to that. So coming back to our components here in the myelocyte. So we have our leukocytes again, which is it increases in bacterial infection, eosinophils and allergies, parasites, basophils, allergies, histamine, and clotting. Our thrombocytes are for your clotting also, the main clotting issues, and then monocytes is phagocytosis. So I'll go over a little bit of what happens when they're too high or too low. And then we're going to move on to our CMP, okay, and LFTs. So your myelocytes here, I'll put it up here. They can either be too high or too low, right? So if there is an overproduction of the myelocytes of the cells in the bone marrow, we call that a myeloproliferation. Okay, and this is commonly an autoimmune disease, right? When there's overproduction of the stem cells. On the opposite side, the opposite of myeloproliferation is myelosuppression. Now, this could be an immune deficiency, right? So let's put that there actually. So myeloproliferation is likely an autoimmune condition, whereas a myelosuppression is a immunosuppression. So this immunosuppression can be iatrogenic. What does that mean? Iatrogenic is caused by treatments, or it could be the patient's own immunodeficiency, right? So as far as immunodeficiency, we know that here more in the CD4 cells is where a very common type of immunodeficiency happens, which is your HIV, right? We'll come back to that in a minute. But as far as iatrogenic cause of myelosuppression, that is your chemo drugs or your immunosuppressants, okay? So chemotherapy or long-term immunosuppressants, or not even long-term, but just a lot, right? For example, in your transplant patients, okay? They are going to need immunosuppressants. So these affect the entire bone marrow. So then if we have myelosuppression, then naturally everything is going to be decreased. So then your RBC is going to get decreased. Your hemoglobin is going to get decreased. And then your leukocytes is going to get decreased. And what we're most concerned about is your neutrophils here, right? Your platelets, that's also very important. And your monocytes kind of goes along with your immunoprotection. So when that happens, then we know that we're going to have anemia. And as far as what happens to our WBCs, our most concern is the neutropenia. And then, of course, here in our thrombocytes, we're going to have thrombocytopenia. Your monocytes may also be affected. But again, that kind of goes along with what we're concerned about in neutropenia. So in our anemia, what are the general signs of anemia? And then later on, I may specify the specific signs of anemia in different types of anemia, okay? So here, let's look at the general signs and symptoms. And so when I say general, that means that it doesn't matter what type of anemia you have, you're going to have these symptoms because of the lack of hemoglobin, which equals the lack of hemoglobin, which equals a lack of oxygen. Right? So technically, that's still lack of perfusion, even though most of the time when we say perfusion, we're saying blood flow, okay, of oxygen-rich blood. So when we have, this is technically called hypoxemia, right? Low oxygen in the blood or in the cells. Then we look at our CNS, and we know that we're going to have headaches, we're going to have irritability, and then we can even have lethargy, someone who gets tired a lot. And that kind of goes along with the musculoskeletal, where they will have the generalized weakness and fatigue. Okay. And then with our cardio, to compensate for the lack of O2, then we're going to have tachycardia, right? Especially during movement. Okay, they might even have palpitations. And if this is really bad, they might even have chest pain. Okay, when there's a lack of O2. And then, of course, in the lungs, to compensate for the lack of O2 in the cells, we're going to have tachypnea. And they will likely have DOE, dyspnea on exertion. Okay, they climb up a flight of stairs, they're short of breath, they walk a certain distance, they're short of breath. And then kind of come back here to the CNS because of the DOE, they may even have pre-syncope or syncopal episodes. Okay, so these are all general signs. So it does not matter the type of anemia that someone has, they're all going to have these symptoms, okay, depending on how low this hemoglobin is, okay? And then we also have different types of anemia outside of myelosuppression. So remember, this one that I've listed here is for myelosuppression. So all of the red stuff here is myelosuppression. Before I move to the other types of anemia, since we're here in red, I'm going to go and we're in the bone marrow. I will go ahead and add what happens when it's increased. So when the RBCs are increased, because we have myeloproliferation here, then that leads to polycythemia vera. Now, there is also what's known as reactive polycythemia. That is not due to myeloproliferation. Okay, so this is an autoimmune. It increases the red blood cell. And so what happens when there's increased red blood cell, and when you see the vera, that means that it's not the good quality. okay? There's an increased production, but they may not last long, okay? They may not live long. And RBCs live up to how many days? 120 days, okay? But these guys, because you're due to myeloproliferation, you can kind of think of this as like Christmas season, and there's an increase on, production, but because sometimes companies will increase production and produce fast, the quality suffers, right? It becomes kind of poorer quality, okay? So this is kind of what happens with polycythemia vera. But at the same token, because there's an increase in RBC, then this patient is at risk for what? Clots. Okay, they're at risk for clots due to the thickening of the blood because there's so much RBC inside. Okay, and also not only that, there's risk of overcrowding. I think I mentioned this when we were talking about perfusion, right? So what do I mean by that? There's risk of overcrowding. What does that mean? Exactly. So then there's potential leukocytopenia, right? Mild. And potential thrombocytopenia. Because there's not enough room for all the cells to grow inside the bone marrow. They're crowded, right? But the most risk you want to remember is the risk for clots, okay? And we'll kind of mention a little bit of the interventions later on, but I don't want to get too hung up on that because we're talking about all the other labs. Okay, but this is, the Vera is, again, the autoimmune, okay? There's another type of polycythemia, which is not autoimmune. I'll go ahead and add that here, maybe in a different color, because that one is not too bad. Here, so also, it's also called polycythemia, but reactive polycythemia. Or reactive or compensatory polycythemia. And what causes this is, what do you think? What triggers the RBCs to overproduce? What? Say again? Hypoxia. And chronic hypoxia, okay? So who gets chronic hypoxia? COPDers, who else? Which would be kind of along the lines of the COPD. When we talked about respiratory, we talked about another chronic disease. We'll say chronic asthma, sure, which is sometimes considered part of COPD. Not ARDS, ARDS is acute. CF, right? Cystic fibrosis. So as far as conditions, and this is fibrosis, so other types of lung fibrosis as well, pulmonary fibrosis. Okay, where there's restriction of oxygen. Or it could also be due to not a lung condition, but location, right? High altitude. Remember, this is chronic. So, well, it takes more than a day, right? For this to happen. And I think some of you may have heard me say this before, but athletes will use this feature of how the body produces RBC by doing, and they do a natural blood doping, right? So what do? They train up in the mountains, right? They exert a lot of effort when they're in the mountains. They jog, they box, right? Because what happens when you're there, you're forcing your bone marrow to produce a lot of RBCs. So now they have reserve RBCs. So then they go down to normal, not, do we call it low altitude? No, normal altitude, not altitude, normal sea level, thank you. And now they have reserved oxygen. So even when they fight, or they lose blood, or they lose energy, then they're still okay, because it's just gonna go back from high concentration to normal concentration of the RBC. Okay, so this is okay, but also to note that you will see that in COPD, so any of these chronic conditions. Along those lines, since we're talking about that, your reticulocytes is also going to increase in these same conditions, okay, as a compensation. Okay, because they're producing more RBCs, and so there's going to be a lot more baby RBCs in the blood. Okay. And commonly with these anemias of chronic disease, that's when this also increases. Okay, so you might see a increase in the width of the red blood cell as well. Okay, and then here in your peripheral smear, you might see again where they talk about ovulocytes. Okay, so you'll see, like I say, presence of ovulocytes, okay, in this type of conditions here. Okay. So back to the other types of anemia. Any questions about that? The increase before I move forward? Okay, so we'll put an arrow here just so we're clear. This is an increase in the RBC. Going back to here, so now we're going to talk about decrease. So now we're going to discuss the different types of anemia, and I'm going to just give you guys the more common types, if you will. And we're going to categorize them based on certain things. And the more common ones is your nutritional anemias. So when we say nutritional, we mean that the body is missing a component that it needs in order to produce a healthy RBC. Okay, so the two general categories of that, and I'm going to put in now the values from the RBC, and I'm going to put here low MCV, and this is known as microcytic. So meaning this is what you'll see in this type of anemia, and this is your iron deficiency anemia. Okay. Now there's also the opposite, wherein there's going to be a high MCV, and this is called macrocytic. Now in your lessons, you may also see this described as megaloblastic anemia. And there's two kinds. These are your two kinds down here. So I'm going to differentiate them just for the sake of technicality. So the first one is folate deficiency. Okay, that can cause a megaloblastic anemia. Now the other one is caused by vitamin B12 deficiency. But I want you to know that the vitamin B12 deficiency is not the anemia. If the vitamin B12 deficiency becomes extreme, then it causes pernicious anemia. And then we'll go over like certain terminologies that for test taking purposes you would want to recognize. That way it's easier for you guys to recognize the answers. So we have nutritional, and then we also have genetic. So our genetic anemias, obviously there's something wrong with the genes that had caused the RBC to be produced abnormally. And that would be the more common ones, I guess, that you guys would talk about are the sickle cell disease, which causes sickle cell anemia. Okay, now I differentiate those two because sickle cell anemia is just one part of sickle cell disease. Okay, and then we also have the thalassemia family. And we can categorize thalassemia as the two main kinds being thalassemia minor and thalassemia major. We'll start with minor, which is more common. And this is a deficiency in the alpha chain of the hemoglobin. And we also have major, which is not as common, and you likely will not see them a lot because they manifest in the womb. And this is a beta chain deficiency. And this kind of connects with the second type that I'm going to talk about. They're interrelated, which is your hemolytic anemias. Okay, so your genetic also are hemolytic. Why? Because kind of like my analogy with the factory, right? Because they're bad quality. So then the body is going to destroy it. Okay, particularly your spleen. The one that is not destroyed as much as the minor, the thalassemia minor, because it's a very slight abnormality. But your sickle cell anemia and your thalassemia will become hemolytic anemias. Okay, and that's when they are low in the RBC. So here we've talked about general signs of anemia that affects the different systems. And then here, let's look at terminologies that will kind of help you identify which type of anemia your patient has based on lab values, which we have covered here, and also based on signs and symptoms. So for your iron deficiency anemia, do you know of any keywords that will tell you this is iron deficiency? Say again? Lethargy is general sign, right? So here, spoon-shaped nails. And chromosis. Okay, so these are the terminologies that would point to iron deficiency. What is chylosis? Not so much the lips, but the corner of the mouth, like these sores in the corners of the mouth. Okay, and then spoon shape, basically they're biconcave. Well, not concave. Yeah, concave. Like they're like this. Instead of like this, your nail, it's like this. Okay, because they're thin. Okay, so spoon-shaped nails. And then as far as symptom, or you can even see it, pica. Okay, what is pica? They eat a food that is not edible, clay, paint chips, detergent, crayons. I have a patient who eats sanitizer that is not pica. That's psychosis due to no, but due to traumatic brain injury. So she had traumatic. No, it's I'm serious. Remember how we talked about the limbic system yesterday, right? So when someone has traumatic brain injury, they get some form of psychosis because of the abnormality in the limbic system. And yeah, so this patient now eats sanitizer. I guess she's very clean. In pregnancy, this will present itself as eating a lot of ice chips. Okay, so in OB, for some reason, that is what is the most common manifestation of pica. So if your patient start saying to you, your pregnant patient starts saying to you, for some reason, I just love ice. I crave ice. And that's the key word, is they crave it. Okay, when they crave it, it's not natural. Okay, if they just say, oh yeah, when it's hot, I like to eat ice. That's different from I crave ice. Okay, so that's possibly pica. So check their hemoglobin and check their MCV. Also, typically with the microcytic anemias, they also will be hypochromic. So there will also be a low MCHC. So that's called hypochromic. And because it's hyperchromic, meaning there's a lighter shade, right? A lighter shade of red. So then what is another symptom? Pallor. Okay. So this patient will be pale. So not all anemic patients are pale. Okay. So where are they going to be pale? Usually in the conjunctiva, right? This is like when you do your assessment, you have them pull their eyelids down, right? And you look at the conjunctiva to see if it's pale, because that could be a sign of iron deficiency anemia. And in the oral cavity, okay? Especially in patients who are darker, you may not see like pallor, right? But you could see it in the inside in their oral cavity. Okay. So yeah, so that will tell you that is typically iron deficiency anemia. In folate deficiency, there's not a lot of specific signs and symptoms. So you would defer back to the general signs and symptoms of anemia. Okay. In vitamin B12 deficiency, so there are couple signs. First, if they are vitamin B12 deficient, vitamin B12 is necessary in nerve health. And so a subjective sign would be paresthesia. Okay, because they're almost not getting enough nutrients, fuel, not enough vitamin B12 in their nerve endings. And so they get the numbness and tingling sensation. Okay, or pins and needles. Pins and needles. Question? Excellent question. Thank you for bringing that up. Let's put that on here. So for these, it's what we look at the most is your hemoglobin. Thank you for bringing that up. I'm going to put that here. So for nutritional, I think I'm just going to add a tier so that the arrows don't get confusing. So here we're seeing low hemoglobin, okay, in all of these, okay, in nutritional. Now in your hemolytic, because it's hemolytic, you're going to see low hemoglobin and low RBC and low hematocrit. That's an excellent question for you. Okay, because they're being destroyed. Okay, here, there's nothing wrong with the count of your RBC, but the hemoglobin inside the RBC is deficient. Okay, and so this is well, I'll come back to the other kinds when I'll make sure to get to that actually in a minute. Let me just color this differently. So low hemoglobin in nutritional, which means all of these in genetic, low hemoglobin as well. But when it becomes hemolytic, now you're destroying all of the whole cell. So that's low RBC, low hematocrit. However, if someone has what is called normocytic anemia, so when someone has normocytic normochromic anemia. So what you're saying is it's a normal MCV, right? Normal MCHC, but low, that down here, low hematocrit, low RBC. Obviously, it'll be low hemoglobin because the RBC is low, okay? So when do we see this instance? Acute bleed. Okay. Hypovolemia. So then what we're saying is there was nothing wrong with the way that the RBC was manufactured. You're just losing a lot of them. Okay. So that's another name for that is your normocytic normochromic anemia. Okay, as opposed to these ones here, there's something wrong from the get-go, from the time that they're being created. Okay. Here, they're just losing it a lot. Now, there's also what's known as anemia of chronic disease. And so in anemia of chronic disease, that it will look like an iron deficiency anemia where they'll have the microcytic and the hypochromic. So I'm going to go back here and reclassify that a different way, just so you have that reference. So I'm going to put, if it's low, it's called microcytic, low MCV is microcytic. And your microcytic anemias are usually, I use the mnemonic tickles. Okay, so tickles, thalassemia, iron deficiency, anemia of chronic disease, liver issues, autoimmune issues, lead poisoning, especially in kids, and siderosis. So siderosis is a condition wherein the iron deposits outside of the hemoglobin, or there's an overabundance of iron, but it's not in the hemoglobin, it's outside. So it could be also an overabundance, like in hemosiderosis, there's an overabundance of iron in the liver. And that could cause your MCV to become low. Okay. Now, the high MCV we've talked about already, which is your megaloblastic. So that's these guys here, the folate and the vitamin B, the pernicious, okay, folate and pernicious anemia. And typically your low MCV, which are your microcytic, are the same ones that are also hypochromic. All right. I want to. Fine. You guys are gonna have a few questions on sickle cell. Oh, sorry. Let me just go back here and tell you a little bit more. So of the keywords. So we got the iron deficiency anemia. These are the keywords: pilosis, wind-shaped nails, pallor, pica, and vitamin B12 deficiency. There's paresthesia, and then once there's pernicious anemia, we might also see some keywords such as beefy red tongue. Okay, for some reason, the tongue becomes inflamed with like a beefy red, like really red color. Okay, but it normally doesn't appear when there's just vitamin B12 deficiency. It normally will appear once it's a full-blown pernicious anemia. Okay, so obviously, if someone has pernicious anemia, they'll have both symptoms. But if they only have vitamin B12 deficiency, they only may complain of paresthesia. Okay, they're also going to complain of weakness, but I don't want you to remember that here because we already have weakness up here with the general signs and symptoms. Okay, that way I want you to just separate out the keywords that you might see in tests that will point to the specific anemia. Okay. And then we know in sickle cell anemia, we're going to have sickled cells. How do we know that they're sickled cells? Remember how I talked about the peripheral smear here? So in sickle cell, so we'll put that here for sickle cell. We're going to have sickled cells in the under the microscope. So that will be the finding in the peripheral smear. Okay. Now, what else do we see in your sickle cell patients? If you recall our concept map on perfusion, so go back to the MSK part of it, where I talked about ischemia and the pain. So that is what explains the pain in sickle cell disease, is because of the ischemia into the muscle. So they'll have severe pain, but I'm going to put some keywords here as well. So we'll add that. So your severe musculoskeletal pain. And then also, I'm going to put acute chest syndrome that you might see in severe sickle cell. So this is a complication of sickle cell. And what acute chest syndrome is the lack of perfusion to the sternum and the congestion in the lungs. So then you'll see chest pain, so sternal pain to be more specific, because of ischemia. And you're going to hear rales due to pulmonary edema. Okay. Related to pulmonary congestion. Okay. So these are the main signs and symptoms that you might see in sickle cell anemia. Now, when there's hemolysis in sickle cell anemia, then we see more symptoms. Now we're looking at overworked spleen, right? Because of the hemolysis, right? So any type of hemolytic anemia, you're going to see an overworked spleen, okay? And again, the more common one that you'll see that in is sickle cell. So you'll see an overworked spleen, and because the spleen is overworked, then that causes it to get enlarged. So you're going to see splenomegaly. And when that spleen gets too enlarged, then you might even see splenic rupture. That is a medical emergency. And that is what causes the RBC to go low because they're all being destroyed. However, the other thing, due to the destruction of the RBC, is there's two waste products. If you've done OB, then this might sound familiar to you. So there's going to be an increased waste from RBC destruction. What are they? Anybody remember? There's going to be an increased bilirubin, right, in the blood. So then that becomes bilirubinemia. Okay, and so this increases your total bili. In your LFT or your CMP, okay? And so we have splenomegaly here as a sign, and then we have bilirubinemia as a sign. Now, in order to get rid of the extra bilirubin, so now that it's in the blood, right? So then it's going to trigger the kidney. So that's the first sign of bilirubinemia, unless you check the total bili. Will excrete the extra bile, extra bilirubin. And so now the patient is going to have bilirubinuria. Right? And how does that present? This is also known as Coca-Cola urine because it's as dark as Coca-Cola. So when you see urine that is very dark, get a LFT or get a CMP. Okay, because and if they have history of a hemolytic anemia or a genetic anemia, then that's probably what's going on, is that they're, and get your CBC because they're probably going through anemia at that point. So then this is number one. And then, so after this is triggered, you know, the kidney only can filter how many mLs per minute? How many mLs per minute does the kidney filter blood? Very good, 120 mLs per minute. That's your normal GFR, right? Glomerular filtration rate. Anything less than that is a sign of chronic kidney or acute kidney disease. So then it goes into your integumentary system, right? And that's when we see jaundice. We see an icteric sclera. We see dry, rough skin, which causes pruritus because you're literally spilling bilirubin to the skin. So when you see these signs and symptoms in someone with sickle cell disease, then you know that they are actively breaking down the RBC. Okay, So they may be keywords for sickle cell, but again, just know that it could be any hemolytic anemia. Okay, any hemolytic anemia, which could be your thalassemia major. Questions about that? Keywords to recognize. All right. I'm going to move on a little bit to your neutropenia. So a neutropenic patient, like I mentioned, will be, I'll move this over here, will be at risk for infection. And so there's two things that we'll look at, right? We are monitoring for signs of infection. And what would those be? What signs of infection are we looking for? Okay, fever, good. How high? Greater than 101.4. What else? Chills, right? I may have mentioned shake and bake in sepsis, right? Fever and chills. What else? We'll tell you there's an infection. Say again. So we'll add that. That's in sepsis. So if they're becoming septic, then we're gonna have tachycardia along with the fever and chills and hypotension, right? And then how do we know that it's actually sepsis? What are the two labs? Lactate and so positive lactate greater than, say again, 2, just 2. So lactate greater than 2. And how else do we know that it's actually sepsis? So lactate is actually not a sign literally of sepsis. It's a sign of ischemia from sepsis, right? We talked about that yesterday also when we talked about neuro, remember? So then what is a sign of sepsis? How do we know that it's actually sepsis? Positive blood culture, right? How do you know that the bacteria is in the blood? You do a blood culture. But the problem is blood culture takes 3 days because they literally have to grow the bacteria to find out what it is and then do a sensitivity, right? But lactate is immediate, it's a couple of hours, you have the lactate result. So you have these clues that there's sepsis going on, okay? And oftentimes this would have local signs and symptoms as well, right? Like if it's a lung infection, you're gonna hear crackles. If it's a UTI, you're gonna see, actually, let's specify that. Just so, because this is still part of your labs. So we'll say local sign and symptom of infection. So if this is UTI, what tells you that it's UTI? Because NGN, you need to know this. Positive nitrite for UTI. I don't look at bacteria because if your hygiene is not that great, you'll have bacteria in there. Okay, you'll also have WBCs, leukocytes in there. So I don't look at those. I look at nitrite because nitrite, nitrous oxide, right? Nitric acid is the breakdown, is the proof that there's breakdown of the bacteria. Okay. In pyelonephritis, meaning it's higher up, right, than just a UTI. It's not just in the tract, it's in the renal pelvis of the kidney. Then we're going to see casts. Okay, so RBC cast and WBC cast. Meaning that the infection is higher up in the kidneys. So by the time that they come down to the bladder and you expel them out, they're clumped already. So the RBCs and the WBCs clump already because they're coming from the renal pelvis. Okay. And then of course in the lung, apart from the usual respiratory symptoms, then we know that there's likely going to be either rhonchi if it's bronchitis or crackles if it's pneumonia, right? And then, of course, in the wound, that's easy. You see pus, right? So if it's in the wound, then you see pus. What is a technical term for a drainage that is with pus? Purulent. Okay. Am I missing another type of infection that's common? Can you think of any more? I think these are mainly it. Okay, does that make sense? So in our intervention, we want to watch out for this. So then when I'm not sure if we'll get to interventions, but basically your no visitors, right? No fresh flowers, nothing fresh, nothing raw. No visitors, nothing fresh, nothing raw for your neutropenia patients. So that's called your either neutropenic precaution or reverse isolation precaution, okay? Or protective isolation. So those are the terminologies that you might see in test questions. They all mean the same thing. They are for a patient who has low neutrophils. Okay, yeah. So remember, normal neutrophils is about around 60-ish percentage. So if they're like at 40, 20, or if they have pancytopenia due to chemo myelosuppression, then all of that is low. So yeah, less than what's normal. And then your WBC will be 2, 3, 1. Question? That's a good question. And kind of along those lines, I want to add cellulitis to here. So because in cellulitis, it's possible to not have an open skin, an intact skin, but you will have that warmth and that edema. I think for your level, it's worth reporting to an advanced provider. And then they're the ones that, will be able to determine, is this an infection or not? Yeah, but definitely there's inflammation, right? Because we talked about signs of inflammation last week. And the edema, usually cellulitis, is pitting. Okay. And it's very warm and it's painful. Okay, and the problem with cellulitis is that the infection could go so deep, same with wounds, that it becomes osteomyelitis. And you won't know it's osteomyelitis until you do a CAT scan. Okay, so definitely worth reporting. Good question. Anything else over here? Okay. So then let's move on to thrombocytopenia. If you've done OB with me, and if you're visual, you'll see this in my where do I have this? The bleeding or disorders. There's like a hole at the top part. There's a whole slew of signs of bleeding. But we'll put that here. So it's bleeding. And so these are the signs of bleeding that we would want to look at. Beginning from our HENT. So we'll have, it could be a subconjunctival bleed. Hemorrhage. These look scary, but they're actually very benign. It's like yeah, like that blood clot that you see on the sclera. You see that, I'm like, oh my God, what happened to you? It's just some blood vessels that ruptured. But epistaxis is another common one, and then gum bleed is another common issue. So bleed, well, not risk, but symptoms. And then in our GI, we might see, so technically hemoptysis is GI or lung, but I'll just put that there because they literally spit blood out, right? Hemoptysis. And then it could be something that is more gross, which is melena. I'm sorry, not melena, coffee ground emesis. Okay. In your ETOH population, or someone with very esophageal varices, then we see hematemesis. So hematemesis is a lot more pronounced. It's bright red blood, right? And a gross amount of blood, a large amount of blood, as opposed to coffee ground emesis. It looks like coffee ground because it's darker blood, but that tells you there's upper GI, okay? So let's actually classify that. So upper GI will include hematochezia. God bless you. Hematochezia is your positive fecal occult blood test, or guaiac, that's the other names. And that's microscopic bleeding, right? And then it could be very obvious bleeding, which is your melena, and that's your black tarry stool. Looks like tar. And then you could have lower GI symptoms. And as we know, if it's lower, it's more bright red blood. So you might see somebody document BRBPR, and that means bright red blood per rectum, usually from hemorrhoids, or again, varicose veins in the rectum, which is what hemorrhoids are. Okay. And then GU, it could be positive blood in the UA, right? Or it could be just hematuria. So when we say hematuria, that's more gross bleeding, again, like something that you could see, okay? It could be reproductive, which, possibly there could be other factors there, but it could be menorrhagia. What is menorrhagia? It's excessive bleeding during menses, or metrorrhagia. What is metrorrhagia? Bleeding in between menses. Okay, in between the menses. And then, of course, if they have like any IV sites, what you might see is just blood leak from the site. Okay, like blood will just spontaneously leak from your injection site. Okay, or it takes a very long time to stop bleeding, like maybe 15 minutes, okay, if they have thrombocytopenia. That's why these people, you'd have to put 10 to 15 minutes of pressure on injection sites. And you want to use the smallest gauge possible, okay, maybe a 22 or a 24 for any IM injections or any IV, okay? because if not, it'll ooze. That's actually a word that you might see more, blood oozing from site. Okay. Let's see. There is anything else on, okay, let's just go through HIV real quick, and then we're going to leave this topic here. So HIV is the virus, right? And then that affects your CD4 cells. So the HIV virus will penetrate the CD4 cell. And then when it penetrates the CD4 cell, two things happen. One, because it hijacks the RNA and the DNA of the CD4 cells, so then the CD4 cell dies, right? And you're going to have an increased viral load. Okay. So this is definitively, the viral load is definitively what tells you that there is HIV virus, obviously, right? Because you're looking at the viral load count. And at the same time, you're decreasing the CD4. So by the time that this patient, if let's say they don't get treatment, okay, so let's just say that this is happening by 2-week time frame. In 2 weeks, their immune system is gonna try to protect them. And so they're gonna have flu-like symptoms. Okay, that tells you that their immune system is working. And at this time, so what else is developing? The antibodies, right? Developing. Okay, that is why you're getting that flu-like symptoms. The same manner that you get flu-like symptoms after a vaccine, right? It's your immune system producing new antibodies. And so by this time, you can do an ELISA test or an RPR, right? Very famous during the COVID times, right? Antibody test. Now these will be positive, okay? So it's possible that someone gets HIV, gets tested the following day and be negative because the virus has not had enough time to reproduce yet, and your immune system has not had enough time to develop antibodies yet, okay? So then 2 weeks later, they're gonna get tested, a month later, they're gonna get tested, 3 months later, you get tested, 6 months later, a year later. If they continue to be negative within that time frame, it's probably safe to say that they are negative of HIV. Now, if for some reason they don't seek care and 10 to 12 years pass by, okay, so 10 to 12 years later, you continue to decrease the CD4 and you continue to increase the viral load. CD4 becomes as low as, anybody know how much? Fourth semester? Less than? 200. Okay, less than 200 CD4. And then viral load greater than? Greater than 40K. When you see this happening, now you have full-blown AIDS. Okay. And so when there's full-blown AIDS, because of the CD4 being so low, right, then your killer cells also become low. Because you don't have any helper cells, right? So because your killer cells are low, then there's nothing that protects you. So then this is when they get the opportunistic infections. And we're not going to get into all of the specifics of that, but I will break down for you that there are different kinds of infections that this patient is going to get. And that could be bacterial. It could be viral. And commonly also, depending on how they got the condition, there might be a comorbid hepatitis C or hepatitis B. And so then there'll be liver cirrhosis. Also very common, they'll get Epstein-Barr virus and cytomegalovirus. So those are the more common viruses that they'll get. Then they will get fungal infection, and this is actually sometimes one of the first ones that will appear, that will send a patient to the clinic because of frequent yeast infection, and then later on they get tested and they're HIV. Okay, so any type of candidiasis infection. Where are they going to get candidiasis? Usually esophageal, rectal, or vaginal. Okay, or balanitis is penile candidiasis. Okay, along with the skin. And then they also will get a lot of parasitic infections. So parasites that they normally will not get, like histoplasmosis gondii, usually we're not prone to, but because of their immune system being low, they'll get that. And then, as I've mentioned earlier, that the killer cells fight against cancer, right here. So now that they don't have enough killer cells, then they are also prone to two types of cancer, which is your Hodgkin's lymphoma and another cancer of the connective tissue, which is your, what is it called? Kaposi's sarcoma. Okay, so these are what they are very high risk for. Questions? So your typical comprehensive metabolic panel, how do you know that it's comprehensive? So it has your electrolytes at the top, and then it has your kidney function. So BUN, the serum creatinine, and then your liver function. Okay, with your BMP, you'll have the electrolytes, glucose, and then the creatinine. That's pretty much it. So at the top here, but I had sodium up there. So normal sodium 135 to 145, right? It's up here. When there's deficiency or excess in sodium, your first system that you want to look at is your CNS, right? That's patient will get a headache, maybe some confusion, lethargy, sometimes even hallucination. Okay, if it's really bad. And then your potassium and medication-wise for sodium, who's at most risk are your patients on hydrochlorothiazide, your thiazide diuretics. So the first thing that we look at electrolyte-wise for thiazide is sodium, because it depletes sodium a lot more than it depletes the other electrolytes. For your loop diuretic, that's potassium, right? So potassium, 3.5 to 4.5. There might be other values, like maybe 5.3. And again, who loses a lot of potassium, your loop diuretic patients. You would want to think about, what potassium does. Potassium is intracellular, right? Sodium is extracellular. That's why the sodium value is very high, because we're checking the blood, right? And so it's abundant in the blood because it's outside of the cell. And the reason also that potassium numbers is very low, because it's not supposed to be abundant in the blood. It's supposed to be abundant in the cell. So when you see this number go up higher than what it should be, it tells you two possible things. One is that there's an overabundance of potassium in general, or maybe the patient's not excreting enough potassium, such as in renal failure, or the potassium is shifting from the cell to the blood, okay? In a patient who's having metabolic acidosis, where they're shifting of the hydrogen ion, they likely will also have hyperkalemia. So you kind of want to associate metabolic acidosis with hyperkalemia, okay? Those two most likely will go hand in hand. And then at the same token, if there's metabolic alkalosis, wherein there's not enough hydrogen ion because of the shifting of the electrolyte, that may lead to hypokalemia. And potassium is necessary in contraction of the muscle. And so if there's low potassium, hypokalemia, you're going to see a flaccid paralysis or generalized weakness, because the muscle can't contract. The opposite happens when there's high potassium. You're going to have a more rigid paralysis. So they will have more cramps, they will have more rigidity. They may still have the generalized weakness, but mainly you want to think about, where's that potassium, what does it do? And with both, there will be problems in the myocardium, where the conduction system is at, and so that may cause this arrhythmias. And we'll talk more about that when we go into EKGs. Sodium and chloride are buddies, right? That's why we have the NaCl, sodium chloride IVs, right? So oftentimes when your sodium is low, the chloride also goes low, or when your sodium is high, the chloride also goes high. Now, another thing to kind of think about with chloride is so associate hydrochloric acid, which is in your stomach, right? And so if someone is vomiting a lot, then they're losing that acid. So then their chloride will also go low. At the same time, when you're losing acid-base balance-wise, that may lead into a metabolic alkalosis, because you're losing a lot of acid. Okay, because hydrochloric, hydrogen and chloride, hydrochloric acid, right? CO2 in the blood, so it says it supposedly is carbon dioxide, right? But technically, this becomes HCO3, okay? Because it's going to combine with H2O, right? So CO2 plus H2O becomes HCO3, which is bicarb, okay? So then you want to kind of think of the normal bicarb value, which is around 22 to 26, right? So if you see like this number here is a little bit on the low end, so does that tell you that this patient has a little bit of alkalinity or acidity? Acidity, very good. Because again, you want to think of this in the blood as bicarb. If we were doing ABGs, arterial blood gas, then we're looking at this as the gas, which is CO2. In ABG, CO2 is acid. Okay, so don't get confused. Okay, and then in addition to that, we're looking at the anion gap, which is basically we're looking at how far is this value from being abnormal. So CO2 plus H2O, so this is your bicarb. Okay, so when remember, when you're looking at your BMP or your CMP and you see CO2, don't think gas CO2, think of bicarb. Okay. BUN, I'm not gonna worry about too much. So blood urea nitrogen, because even like dehydration will cause that to slightly elevate. We're concerned if it's like, or, you know, well, not concerned, but it becomes something that you kind of would want to look at as far as, again, dehydration or concentration of the blood in when it's about 40. This is your serum creatinine. This is what we'll look at for kidney function. Okay, so this patient here has a slightly higher creatinine, right? Which is what's normal creatinine again? 0.8 to 1.2. So 1.2 or 1, right? So like here in this particular lab, it's 1.18, but they already are marking it as high, right? Because it's a computer. But what you would want to compare that with is two other things. So again, remember that creatinine, serum creatinine tells you the kidney function. That's the first thing we look at. And then you look at your output, right? Your urine output. So if that output is less than 30 mLs per hour for 2 consecutive hours, then you know we have kidney impairment. It could be an acute kidney injury or it could be chronic kidney disease. But when they're not peeing enough, then something's wrong with the kidney. And then you also compare that with your eGFR. Okay. So I believe we talked about this when we were looking at perfusion, right? Do you guys remember what stage this would be at 47? 3A, good. So, and that's really when we just kind of start paying attention to it, is when it goes into stage 3, which is less than 60, right? If it's like stage 1, stage 2, it's not going to get highlighted. Like this one is not even highlighted. But your patients with diabetes, hypertension, hypercholesterol, sepsis, you know, again, you want to correlate that with your serum creatinine. So this patient's kind of borderline as far as that's concerned. Their random glucose. What is normal random glucose? Random, not fasting. So when we say random, they could draw at any time. They didn't have to be fasting for 8 hours. 180. Okay, less than 180 is random. Greater than 126 is fasting. Okay, and I'm talking about diagnosis wise. In management, like you guys would probably report, what do you report? Greater than 110? Yeah. So if it's greater than 110, you say, oh, that's kind of slightly elevated, you know, doesn't necessarily mean that you're going to give medications, depending if there's a sliding scale or not. So greater than 180 for random, greater than 126 for fasting. Okay. And then your serum calcium, you want to think of the first system that you want to look at if this is either too low or too high. And what's normal serum calcium? 8.5 to about 10, 10.5, 9 to 11. So this person is at 9.2, so that's pretty normal. If it's extremely high, the first thought, if it's mildly high, so like 11.5, let's say 11.2, 10.7, depending on the values of the lab, you want to think of the parathyroid hormone, right? So that's the first gland that we would look at. So because that is what controls the calcium level, the serum calcium level. So if there's hyperparathyroidism, this value will go up. If there's hypoparathyroidism, that value will go low. Okay. If it's extremely high, greater than 15, that is not the parathyroid. That is possibly a sign of cancer. So it's either a primary cancer in a patient who has osteosarcoma, or it could be, this is my guess, You can sit anywhere. She's just sitting in. She wants to be a nurse. She's an El Camino student though. And then osteosarcoma or bone metastasis. So if it's greater than 15 and you have a patient who has history of cancer, you want that patient's labs to be checked again. You want to report that to the doctor because they probably, even though they don't have cancer at that time, but they have a history of breast cancer or prostate cancer before, that cancer may have come back and is now has metastasized to the bone. Question? 8.5. Yeah. And if their calcium is low, you want to check their vitamin D because probably they're low in vitamin D because vitamin D is what absorbs calcium. Yeah, that's almost all of us here, right? But that's important, especially females, because if your estrogen, your calcium are correlated. Okay. So when we get to menopausal stage where your estrogen goes low, your calcium is also going to go low. So you need to reserve that calcium now. Okay. Now it's not part of this lab, but phosphorus or phosphate, is it in here? It's not in here. Phosphate is cousins with calcium. So when no, this is liver. This is liver. So, but phosphate or phosphorus, it is what it would show on here. So calcium and phosphate are both supposed to be in the bone and the teeth. Okay. So when your calcium is low, your phosphate is probably going to be a little low as well. Except, so fourth semester, pay attention to this, except in kidney failure. So when someone has end-stage renal disease, their calcium will go low, but their phosphate will increase. Basically, all the other electrolytes will increase, except calcium will go low because in the kidneys is where calcium resorption happens. And so if the kidney is failing, calcium is not being resorbed, it's not getting released to the blood. And so calcium will go down. That patient who has kidney failure will be at risk for fractures, okay? And will have osteodynia, bone pain, also because of that, okay? So liver, we look at the liver enzymes. So AST, typically AST, ALT are the two that we would look at. And those values will be higher than 40s if it's too high. So that will indicate an inflammation. Okay, so high AST, high ALT will tell you there's an inflammation in the liver. When does that increase? Starting from steatohepatitis, fatty liver disease, right? Fatty liver disease, or a acute hepatitis B or any other type of hepatitis, including alcoholic hepatitis. Okay. In liver cirrhosis, this may continue to get increased. It could be as high like 60s, 70s, maybe, in liver cirrhosis. Their phosphatase and their protein, so all of these proteins here, ALP, total protein albumin globulin, may actually decrease. So the worse the liver cirrhosis becomes, because these proteins come from the liver, their numbers will go down. Okay. So that tells you that the complication of that, if the albumin is low, if the protein is low, is that their wound healing is going to be poor, right? And also in patients with pressure injuries, with bed sores, we do look at the albumin level. And if that is not at the normal level, then we're going to need to add albumin because, again, the wound is not going to heal. Yeah. The AST/ALT? Yeah, any type of inflammation to the liver. Yeah, they will increase. Not so much the flu, because that's more systemic. Inflammation in the liver. Inflammation in the liver. I've seen I've seen AST, ALT high also, and you're like, what's going on? I don't have an inflammation, but these are people who may be drinking a lot of herbal teas or a lot of like supplements. Because remember, anything that passes through your mouth goes through a first pass, right? The first pass is that before you get the active metabolite of the drug, your liver has to metabolize, break it down first. So then the more medicine you take in through your mouth, doesn't matter what medication, it's going to affect your liver. Okay. Yeah, I've seen it like increase. Now, at the same token, milk thistle improves liver health. Okay. Another thing that improves liver health, glutathione. So it's an enzyme, glutathione. So it's an enzyme where it could be an infusion or an injection that people might get. In the Asian community, glutathione is famous for skin whitening. Glutathione as an IV infusion, but it's actually the excess of it. It's kind of like the same concept of when you get pruritus because of so much bilirubin in your blood. So same thing, when you have excessive glutathione in your blood, it goes into your skin and it whitens your skin. Okay, so we talked about WBC. So this is just kind of a look at, all the other things in the WBC. One thing that I want to point out that I didn't point out before is this MPV. So MPV is this almost similar to RDW, or I'm sorry, to MCV. So MCV is the size of the RBC, right? MPV is the size of the platelet. So in instances wherein someone is anemic, okay, the platelet sometimes will compensate because in the mind, if you will, of the bone marrow, when your hemoglobin is low, they're thinking, oh, you're bleeding, right? You must be bleeding because your hemoglobin is low, right? So then what is it going to do? It's going to try to stop the bleeding. And so you're going to see a reactive thrombocytosis. You're going to see the platelet go up in anemia because it thinks that it's helping, right? And so then you're at risk of clots. And how do you know that that's happening is the MPV is going to go high as well, because it's producing more of it, and it's producing an abnormal quantity, so it becomes more wider, more larger, because it thinks that it's there's a bleeding going on. God bless you. Okay. So you'll see like two different values here. So you see the percentage of the differential that we talked about earlier, right? So this is in percentage. And then these are the absolute counts. So they just measure it a little bit differently in the microliter as opposed to the percentages. Okay, but it's the same thing that they're looking at. Okay.